Hello and good evening. Welcome to Fund a Fellow entitled Cognitive Issues with Parkinson's Disease. I want to thank everybody for joining us for Fund a Fellow tonight. From my bottom of my heart, I want to thank everybody for everything that they've done over the years to support the Fund a Fellow program that has been able to train our fellows in movement disorders, so neurology residents that have finished their training program into well-established movement disorder specialists, which are greatly needed. Also, it's been a different year, a very difficult year for a lot of us. So we're all looking forward to 2020. We keep getting good news about these vaccines. So we'll probably talk a little bit about that this evening as well. And we've seen the first vaccine approved. We saw a provisional approval this evening with the second one. So hopefully this is the beginning of the end. And hopefully 2021 is going to be a much better year than 2020. So tonight we're going to talk about cognitive issues in Parkinson's, and I have two really esteemed guests that I'll introduce in a second. But this is a very important issue in Parkinson's disease and in Parkinsonian disorders as well. So and just in neurodegenerative diseases. So if you take a look at neurodegenerative disorders, Alzheimer's disease is the most common one. We have about 5 million individuals who suffer from Alzheimer's disease in the United States currently. And we have about 1 million individuals with Parkinson's disease and probably another 1 million individuals with Lewy body disease. But if we don't find something to really stop or slow down the progression of the disease, we're going to have about 15 million people with Alzheimer's disease by the year 2050, and we'll have about 5 million individuals with Parkinson's and Lewy body disease by the year 2050 if we don't find something to slow down the disease progression, because we are definitely living longer and our population is increasing. So cognitive issues are something very important in the neurodegenerative disorders, and tonight you're going to learn how this happens, and you may see that there's a lot of similarities among those three disorders that I mentioned and several other ones as well. Why is it important? It's very important because we see these in these disorders and neurologists need to be properly trained. And our Fund a Fellow program is probably one of the first where we take fellows that they're working together, not only with movement disorder specialists, but also memory disorder specialists. And you're going to hear we have probably one of the world's best translational neurotherapeutic programs in the country, led by Dr. Moussa, which we'll talk a lot about. So I think this is going to be an exciting topic. And to join me on this topic, I'll introduce our panel. But before I start our panel, we've been very successful in our research over the last almost decade, probably more than a decade, and Dr. Moussa can be more specific about it. I've been lucky and fortunate enough to be working with him for over 7 years now. And we've been very successful with a lot of the technology that he's discovered. And we're so successful in the phase 1, phase 2 clinical trials that we felt it was necessary to spin this out into a pharmaceutical company outside of Georgetown to move things faster. So I do have to let out a disclaimer that all three panelists are involved with a small pharmaceutical company called Kiefer. The Kiefer RX is the way we call it. We just leave the X silent, which we hope to see phase 3 clinical trials in some of these neurodegenerative disorders that we're going to talk about this evening. So wanted to have that disclaimer before we start. Now, the first person I'm going to introduce is Dr. Charbel Moussa. We call him Charlie, but Dr. Moussa has been so instrumental in the movement disorder program and also with our fellows. I think our fellows get phenomenal education because of what we've learned through him and all the research that we're able to do. He's the director of the Laboratory for Dementia and Parkinsonism. He's a scientific and clinical research director for the Translational Neurotherapeutics Program and the National Parkinson's Foundation Center of Excellence. He is also one of the directors of the Lewy body Dementia Research Center of Excellence in the Department of Neurology, Associate Professor. So Dr. Moussa, welcome. We're happy to have you here. And then we also have the esteemed Dr. Torres-Yaghi. Dr. Torres-Yaghi is an assistant professor of neurology, and he's our director of the Parkinsonism and Dementia Clinic. He's also a co-director of the Lewy Body Disease Research Center of Excellence as well. Very instrumental in cognition and in Parkinson's and Lewy body disease research with our group. He was also one of our fellows that we're able to train. And as I often have said in these meetings, I love training my future colleagues. And I think Dr. Torres-Yaghi is an example of a colleague that we were able to train through the fellowship program. And we're now able to really benefit from the fact that he is also helping train future neurologists in movement disorders, as well as participating in research. So welcome, both of you. Welcome, gentlemen. I'm so happy to have you both. And the first thing is, I'm going to ask Dr. Moussa. Dr. Moussa, can you briefly explain what are some of the cognitive issues that our Parkinson's patients have? What are some of the complaints that you hear that our Parkinson's patients have in terms of cognition? And what does that mean, cognitive issues?
Right. Thank you, Dr. Pagan, and good evening to all the participants in this very critically educational fellow program. I just want to start by really highlighting some of the importance of cognition in Parkinson's disease. So traditionally, movement disorders specialists, the entire field of Parkinson's disease, more or less ignored the dimension of cognition in the disease, because, you know, for the last 50 years, we have been trained that Parkinson's disease is a movement disorder. But over at least the last 10 years, the understanding of Parkinson's disease has, you know, significantly shifted to Parkinson's is not just a motor disorder, it's actually a whole body disease. It's a motor and non-motor disease. So having that understanding really brings us to the issue of the non-motor and particularly the cognitive issues in Parkinson's. In Parkinson's disease, there is a lot of cognitive issues that may be subtle, or in some patients it may be more obvious than others since the early onset of the disease. Now, there is one thing that we should really know, that cognition or cognitive impairment does not mean dementia. And one of the, I would say, the problem or the problems or the confusion historically has been, well, I don't have any cognitive issues because I remember everything, you know, as a patient. Or, you know, my, the caregiver, like, you know, my beloved one does not have cognitive issues because, you know, they remember everything. But that's true. Cognition does not mean dementia. Dementia is one type of cognitive impairment. In Parkinson's disease, due to the fact that first, we do not have initially in the early diagnosis of the disease, we do not have a certain diagnosis, which means it could be Parkinson's or it could be any Parkinson's-like or Parkinsonian disorder. And in this context, in all of the above, if you like, the impairment of dopamine is important. Sometimes the impairment of dopamine is not so obvious, okay? But what is obvious is the cognitive impairment that we see typically in Parkinson's disease is related to what we know of as executive functioning. Executive functioning is the know-how, do everything in life, okay? So one of the main things of executive functioning is like multitasking, the speed of processing of information. It can also be related to some mood changes or fluctuations in the mood, like anxiety, weeping, you know, happiness, elation, you know, all of these things that may or may not be confounded with the effects of medication as people start treatment. So there are cognitive issues in Parkinson's disease that are not dementia, and these are mainly related to what we know of as executive functioning, which is also shared with other neurodegenerative diseases like Alzheimer's, Lewy body dementia, and so on.
So I think that's a very important statement that you said, so we can see cognitive impairment or difficulties with thinking, processing information, or storing information is different from dementia. Well, Dr. Torres-Yaghi, can you tell us on a clinical level, how do we follow individuals for cognitive issues? What do we do?
Thank you. So it really relies very much on our clinical skills and what we were trained in fellowship, right? So with the blend between Dr. Pagan and Dr. Moussa, we've really been able to create a specialized clinic that not only focuses on the motor symptoms of Parkinson's disease, but also focuses on the non-motor symptoms. And one of the non-motor symptoms could be cognitive impairment. And it's been shown that up to 20% of patients that present to a Parkinson's clinic may actually also have some degree of cognitive impairment, as Dr. Moussa was mentioning, in particular executive dysfunction. So what we tend to do is use all of the different things that we learn throughout our residency and fellowship. Through our clinical examination, our neurologic examination, we do what's called a quick mental state exam. So we ask about orientation, to time, to place, date. We tend to ask questions that might be a little bit tricky. We'll ask a question like, how much money is in 7 quarters? And they might seem simple, straightforward, but we start gaining more and more information with questions like that. The other thing we tend to do, and it tests attention, is we ask people to spell the word world backwards, for example. Spelling the word world backwards can be tricky. If we don't do it all day long, it would be hard for us too. But understanding the processing speed, the cognitive agility, the ability for our patients to be able to answer certain cognitive questions is very helpful. And then we use standardized modalities. So we'll use standardized examinations like the mini mental state exam, which is a test that examines different components of cognition. It's not all memory. It will test all of the different parts of our cognition. It's a score that we can get 30 out of 30 on. That would be the top score. And if we see that there's a deficit, then that might tell us the degree of cognitive impairment that we see. There's a tougher test, which we're trained to use, that we use in our clinic, called the Montreal Cognitive Assessment. Again, it's scored out of 30 points, but it allows for us, when we have a tougher test like that, it allows for us to really look at the areas of the brain and the components to cognition that might be affected.
So definitely. So we have these screening tools, and then with these screening tools, sometimes we could do some formal neuropsychological testing for some people, depending how they're doing. And actually, one of the things that we've done in our clinics is we've created a comprehensive cognition clinic. And all Parkinson's patients should have a screening of cognition at least once a year. And if they haven't, if there is a deficit and we're using certain treatments, we will begin to follow them a little bit closer. Sometimes we'll do that at least twice a year, et cetera. So there are things that we do, and we're definitely we started this comprehensive cognition clinic led by one of our nurses, Joy Arellano is part of it. We're specializing our fellows into being involved with it as well as some of the residents in the near future. But you're going to see a really concerted effort over the next year to make sure that all patients who are being followed in our Parkinson's and dementia clinics are tested yearly, as recommended now by the American Academy of Neurology and the Movement Disorder Society. So this is a new feature in our clinics, and this is a very special area of interest, especially as we get better treatments. I think is going to be very important So, Dr. Torres-Yaghi, can you briefly explain the most common medications that we use for memory? So, if we do notice that somebody may have a memory disorder or mild cognitive impairment or dementia, what are some of the medicines that we have access to?
Great. So after we use the screening tools that we mentioned, if we find any sort of dysfunction, the good news is in Parkinson's disease, cognitive impairment, there's a lot that can be done to help. And so the question that Dr. Pagan asked is the medications that we use. We actually use medicines that have been approved for Alzheimer's disease and for Parkinson's disease, cognitive impairment. But we use those medications oftentimes in combination. So the two big families of medicines that we use are called the acetylcholine esterase inhibitors. So that's a lot of syllables. And so, but when we say that, what Dr. Moussa was alluding to was that it's all about chemicals in the brain, right? It's not all dopamine. When it comes to cognitive impairment, acetylcholine is the chemical that's important. And then there's another chemical or receptor that we tend to modulate. It's called glutamate. And so there are two families of medicines that we use that fall within those two categories. Now, Exelon or rivastigmine is one that has been studied very much regarding Parkinson's disease cognitive impairment. It's the patch, and it's worn and it's replaced every day. It's worn for 24 hours, then replaced. And we use it in our patients with Parkinson's disease cognitive impairment or dementia to augment the levels of acetylcholine. You can also think about using other medicines called donepezil or Aricept, and another one called galantamine. Those are the ones that are typically used. In our practice, we tend to try to use Exelon because it's been well studied in Parkinson's disease. The other family of medicine is there's one drug that we tend to use within it. It's called Memantine or Namenda. And what that does is it affects the glutamate receptors, and it allows for memory to be improved. But if you think about memory loss in terms of context of those two chemicals or those two neuronal pathways, it helps us understand what's the best way of treating. It's not uncommon for us to combine those two medicines. So you might see a patient of ours either on donepezil and Aricept and Namenda and Memantine, or they'll be on an Exelon or rivastigmine patch in addition to the Namenda or Memantine.
So thank you, Dr. Torres-Yaghi. There's already been a question asking about, I think there's 2 points in the question. The first one is an individual with Parkinson's with cognitive issues, and it sounds like they're waxing and waning throughout the day, sometimes doing well, sometimes not doing so well, but they're on 10 milligrams of donepezil. So the question is, what else can you add? So you can definitely use combination medicines like using acetylcholine esterase inhibitor to increase acetylcholine for helping the memory. And you can add Namenda. But the donepezil has a wide range of dosing. It's anywhere from 10 to 23 milligrams a day. So that could be augmented if needed as well. And just like we do have 3 different strengths of rivastigmine that could be used along the way. So definitely always discussing with your healthcare provider what the right dose, could there be an increase in dosage, could you use combination medicines, could be beneficial. Dr. Moussa, why is it with these cognitive disorders, especially with Parkinson's disease, cognitive issues, and Lewy body disease, we kind of see, especially with Parkinson's disease dementia, we see a waxing and waning of the of cognition, and that's usually a diagnosis for Lewy body dementia, but we do see it with Parkinson's dementia. Do we have an explanation of why that happens, or is that just one of the characteristics that we see?
Yeah, it is one of the characteristics that we see. I think we don't have a perfect explanation for this. We can speculate about the phenomena here. So Dr. Torres-Yaghi mentioned something really important about the drugs. So if you are targeting glutamate or acetylcholinesterase with acetylcholinesterase inhibitors, see, Dr. Yaghi, I'm really having a problem also with long syllabus. Okay, so what these drugs or what these chemicals are involved in. They are basically involved in memory storage, in memory retrieval. So the storage and retrieval of information are very important. Now, dopamine is a completely different game. Dopamine is more involved in what we think is the immediate response to our environment, and that is the executive function. So the waxing and waning, okay, could be in Lewy body dementia. In Lewy body dementia, it's a whole different area, I think, of both neuropathology or anatomical pathology, if you like, compared to Parkinson's and Alzheimer's disease. In Parkinson's disease, probably the waxing and waning are more of a result of the wearing off of the patients on the current treatment, basically, and most importantly, levodopa. Now, in Lewy body dementia and in Alzheimer's disease, there is this protein that accumulates in the brain called amyloid, beta amyloid, or what we know commonly as plaques in the brain. This protein accumulates predominantly in the frontal lobe, in the frontal area of the brain. This is what we call the seat of awareness of in our brain. So the seat of awareness in our brain is really the frontal lobe. The seat of awareness is the waxing and waning is probably explained at best like lucidity of the patient. Maybe the patient feels really great right now, and then 10 minutes later they completely lost it. So that is really a function of the frontal lobe. That is really a function of what the frontal lobe does. Because amyloid plaques accumulate predominantly in the frontal lobe, we see we see more fluctuation in Lewy body dementia, because a patient can, and that affects electrical messaging in the brain, affect chemical messaging in the brain. So at certain times or at certain moments throughout the day, a patient might have a proper physiological functioning in their frontal lobe, and therefore they are lucid and they can think clearly. And sometimes, they lose the effectiveness of this chemical and electrical messaging in the brain, and then, that lucidity is lost. In Alzheimer's disease, the game is very different. In Alzheimer's disease, what we have mostly affected is memory storage and retrieval, okay? So an Alzheimer's patient will probably start to forget things that are in the most immediate past, and then remember things that are in their childhood. So the best example of that is if my first language is French, okay, and I learned English later in life. If I develop Alzheimer's disease, I lose English first, and then I retain the French language. So that, that's called retrograde, loss of memory. That is mainly affected by the retrieval and storage of information, specifically, the acetylcholine and the glutamate. But because, and this is the most important thing, which is probably the common denominator in all these diseases, these chemicals act in unison in the brain, okay? So if you have a surge of dopamine, acetylcholine is also regulated. Secretion, use, uptake, metabolism of these chemicals is regulated by one of the or the other. So serotonin, acetylcholine, glutamate, and dopamine are all, the brain is a network. So this network, if you have a faulty transmission in one of these chemicals, the entire brain becomes faulty, or the entire transmission of the brain becomes faulty. So that if you like, that integrative function of neurochemicals or the chemicals in the brain is lost. And then, it can be lost in different patients depending on different stages of disease, different ages, different genes, different reasons for the onset of disease. And that's why we see waxing and waning. We see it maybe because one chemical is affected at one time more than the other. But the waxing and waning is predominantly a function of the frontal lobe. And in the frontal lobe, that's where we have most of the dopamine action. Most of our dopamine action is in the frontal lobe.
Okay, so I think it's important to state, just for everybody to be on the same page, when we say waxing and waning, sometimes our patients look like they're completely lucid, they're firing all cylinders, they're doing well. And then an hour later, it's like you never had that conversation. You can see there's kind of a different look to their face, a little bit more confused, et cetera. Another important point that I think that Dr. Moussa made, about all the different chemicals, is that there's a lot going on. So just because you're missing acetylcholine, because you're missing acetylcholine in one area for cognition, you can also see, because you're missing acetylcholine, there may be other things going on within an individual. For example, we often see clinically when we evaluate our patients for cognitive disorders that memory and balance tend to go together. So we're seeing memory issues, we're seeing cognitive impairment, more moderate cognitive impairment. We can also see balance issues. And we've seen in clinical trials when we replace the acetylcholine deficit in Parkinson's, we see improvements both in the balance, walking, as well as memory. So we've seen that in clinical trials as well in clinical research. So it's really important to understand that there's multiple chemicals, as Dr. Moussa and Dr. Torres-Yaghi have already stated, that can be in disarray in Parkinson's. And we use kind of like a cocktail approach. And a lot of these medicines came out for Alzheimer's for cognition, but they work a lot better in Parkinson's, mild cognitive impairment, Parkinson's, dementia, and Lewy body disease than they do in Alzheimer's disease. But let's review a little bit of the research now, Dr. Moussa, if we can get our audience a little bit up to date with what's happened, especially with the translational neurotherapeutic trials, or the translation neurotherapeutic. We're all having syllable problems today. So the translational neurotherapeutics program trials. What are some of the updates, especially when it comes to Parkinson's and Alzheimer's, and then maybe give a preview of where we're headed with Lewy body disease?
Yeah, I think there are some very, very exciting stuff there. And, I'm not biased, okay? I'm just like saying that because this is what I see in the data. So what are the first things that we see? We started this conversation by talking, and the topic of tonight is cognition in Parkinson's disease. I think the cognitive impairment issue is paramount in Alzheimer's, as well as Parkinson's, as well as Lewy body dementia. And I think one of the earliest, okay, and it's not just something that I believe, it's basically where the field is headed right now. One of the first areas of cognitive impairment is really the executive functioning. So executive functioning impacts or pretty much is measured by what we call mild cognitive impairment, or MCI. So MCI, or mild cognitive impairment, does not really mean that the patient is demented. It means that there is a predisposition for the patient to become demented, maybe, or maybe not. Or the mild cognitive impairment means that, there are some cognitive functions that are impaired, like what we talked about before, this in the multitasking and so on. So in research, there are things that we know about in other diseases other than Parkinson's, like Alzheimer's disease. And I just want to start with that. In Alzheimer's disease, the dimension or the effect of comorbidities has been very thoroughly researched. And we know that comorbidities do affect the age of onset, the speed of progression, and pretty much how long a patient would live with Alzheimer's disease. One of these things that we think that as a result of comorbidity can affect the brain is what we call vascular dementia, or changes in vascular or the vascularization, or if you like, the blood vessels that go into the brain, distribute oxygen, distribute blood, and make the person completely aware of their environment. But what we see in Alzheimer's disease, one of the first things that get affected in the brain before we see much changes in these neurotoxic proteins, is changes in the vascular, if you like, distribution in the brain. Now, in our research, now in a translation neurotherapeutics program, I'm better at pronouncing it than Dr. Pagan tonight. One of the things we've seen, and thanks to all the patients who participated in our phase 2 clinical trial in Parkinson's disease. So if you remember, we had 75 patients or participants, 25 were on placebo, 25 were on 150 milligram of a drug called nilotinib, and 25 were on 300 milligrams of nilotinib. Now, if you only take the placebo group, and this is why it's so important when you do research, that you can learn a lot, okay, about what you want to do next, or where you're heading next. It's not just a control for the treatment, it's also something that will teach you about the disease. Over 1 year, from beginning to 12 months, patients who received the placebo had a lumbar puncture to collect cerebrospinal fluid at baseline and after 12 months. What we did a sophisticated next generation whole genome sequencing of the entire microRNA genome in the brain. MicroRNAs are very important chemicals, if you like, or molecules that can really determine what proteins or what genes do in the body and what pathways they belong to. So what we found in this, sophisticated state-of-the-art whole genome sequencing study, we found that over 1 year from the beginning to the 12 months period when the patients were just on placebo and they were on all the existing treatments that we know of right now for Parkinson's disease, we see that microRNAs that are responsible for the maintenance of what we call the blood-brain barrier, the vascular tissue in the brain, we see an ongoing destruction of blood vessels in the brain. This is something very new. This is a breakthrough in Parkinson's disease because in Alzheimer's disease, we know this is the case. We know that mild cognitive impairment is a result of these very early and subtle changes. In Parkinson's disease, we did not know that. There is something called vascular Parkinsonism in Parkinson's disease, and that's mainly attributed to, a mini stroke or some, hemorrhage in some of the brain areas that are involved in control and movement. But now what we see that, there is a clear sign of destruction of these blood vessels in the brain. So that's very important because prior to this research, we did not know what really causes this early cognitive impairment in Parkinson's disease. The other thing that we've known, we've seen, in this phase 2 trial, the patients who were enrolled on purpose, okay, with mild cognitive impairment. So as Dr. Torres-Yaghi said, we used the MOCA and we determined if the patient is actually cognitively impaired. So in these patients who were cognitively impaired, the patients who took nilotinib, which is a class of drugs called tyrosine kinase inhibitors, over 27 months, okay, they did not decline at all, okay, they were stable. Now, the latest research and the hottest and the most, now people are in the field are very excited about came out of the University of Pennsylvania. They showed in 367 patients, if a patient has mild cognitive impairment and Parkinson's disease, so MCI in Parkinson's disease, after 5 years, all of the patients who have MCI develop dementia. So this is probably due to the fact that we have more destruction of blood vessels in the brain. It has nothing to do with dopamine. It has nothing to do with the traditional way we learned how to treat Parkinson's disease, which has become probably some of an automatic function. Like we drive a car, a movement disorder neurologist thinks this is exactly how we treat the disease. But the fact that we now know that there is a vascular dimension in the disease, this opened a whole new if you like, area for both the diagnosis and the treatment of dementia in Parkinson's disease. Added to that, we see that when we looked at microRNA changes that were actually responsible for the destruction of the blood vessels in the brain in the placebo treated patients, we see a reversal of this microRNA function and level in the patients who were treated with the 300 milligrams and 150 milligrams nilotinib. So here, I think, with the latest research that we see there, we see that, nilotinib is preserving the vascularization of the brain, preserving the remaining blood vessels in the brain, and all indications show here in our trial, in our data, that there is a protein called vascular endothelial growth factor, VEGF, which has been very hotly debated and very well researched in neurodegenerative diseases. It actually promotes the formation of new blood vessels in the brain. So with this decreased blood flow in the brain as a result of destruction of blood vessels, we get loss of our cognitive functions. If we have more blood vessels, more perfusion of blood and oxygen, we should have more cognitive function. And one more thing I want to add, which corroborates this finding, is what we see in the Alzheimer's trial. As you know, in the Alzheimer's trial, we included patients who had mild to moderate Alzheimer's disease. So these patients are at least five years after the onset of MCI. So they are really demented patients. In these patients, we had half in the placebo group and half in the nilotinib groups. Over 1 year, we see that the executive functioning in Alzheimer's patients, which is the first affected cognitive, if you like, faculty in the disease, there was no change whatsoever in executive functioning in the nilotinib treated group versus the placebo group. But because of the small size, we cannot make a decision. But the decision we can make is when we look at what we call the biomarkers, at the amount of protein that accumulate in the brain. We see that in the nilotinib treated group, particularly in the frontal lobe, where most of the amyloid plaques accumulate and where most of dopamine transmission takes place, and where executive functioning is mostly affected, we see a significant reduction in the amount of amyloid in the frontal lobe. So if we add the Alzheimer's data to the Parkinson's data and what we know in the field today, it sounds like if you increase blood vascularization, if you increase blood flow into the brain, you should improve cognitive functioning, particularly in the early stages of the disease. And that's why it would be strategic to target mild cognitive impairment in these patients and try to stop it there. The existing treatments today, okay, if you have 1,000, and the American Academy of Neurology had this quiz once. If I might just add this one last thing, Dr. Pagan. So there was about 15,000 people in the room, and I asked the question, do you think acetylcholinesterase inhibitors are beneficial? Half of the physicians in the room said, no. And half of the physicians said, yes, but maybe for a year, okay? And the evidence points to a year benefit with these drugs. Now, you can give some drugs today for a year, and then a year later give another type of drug, and you can manage cognition for a while. But what, the shortcomings of these treatments right now is their inability to sustain the benefit, okay, for a longer period of time. If we interfere with vascularization of the brain very early on in Parkinson's disease, okay, like we have right now shown in the nilotinib studies, it's very likely that we can stop cognitive decline, and those patients who are diagnosed or get mild cognitive impairment in Parkinson's disease will not develop dementia, or if they do, they'll probably develop it much later than the 5 or 6 years which we see right now.
So I think this is very exciting research that is going on, and we continue to learn more about the nilotinib story and these tyrosine kinase inhibitors. So just to recap, not only do we see a reduction of these misfolded toxic toxic proteins like alpha-synuclein in Parkinson's, tau, Parkinson's, Lewy body disease, and Alzheimer's disease, and then beta amyloid. So the research really shows there, but now we're seeing basically the DNA changes, the microRNA changes in response to nilotinib and benefiting, or almost like a revascularization. So making that blood-brain barrier more intact. That's extremely exciting. And I think, this is groundbreaking. And again, this is great research coming out of Dr. Moussa's lab. And I think every year I work with Charlie, Dr. Moussa, I learn even more. And you sit back, and some of the risk factors for developing cognitive problems are things like diabetes, hypertension, hypercholesterolemia, which impact the vascularization of the brain. So that's why we have things like vascular dementia. So, a drug like nilotinib could potentially be a treatment for vascular dementia. So it's really exciting. I think we continue to learn from this. One of the questions that we got through the chat today, Dr. Torres-Yaghi, is if you get diagnosed with Parkinson's disease, how many patients with Parkinson's end up with dementia? How long does it usually take to show that up? So again, we made a difference between mild cognitive impairment and dementia. So now we're talking about true dementia. What percentage of patients develop dementia, and what's the average time? And does everybody develop dementia?
A great question, and it's a hard one to answer. What we can say about cognitive impairment and its relationship to Parkinson's disease is that, as we mentioned, there might be a certain percentage that on initial examination may have a certain degree of cognitive impairment. As Dr. Moussa said, the main difference between mild cognitive impairment and dementia tends to be whether or not there's a functional impact aligned with the memory problems. Another important piece of that is that it's not all memory, right? So we talked about executive dysfunction, attention, abstract reasoning. There's different forms of memory. There's remote long-term memory. There's short-term memory. There's working memory. If you go to a waiter back in the day before coronavirus, when we could go to restaurants, you might be so excited that a waiter might be able to remember everyone's order, and all the specific kind of caveats to each person's order. They would store it in their mind and then be able to go back to the chef and say, if there were 10 people at a table, he or she might be able to regurgitate all that information. That's another kind of memory, a working memory where people can store quickly and access those memories. So we have to understand first what kind of memory loss or cognitive impairment we're dealing with, because there's so many ways to treat it. We talked about the acetylcholine esterase inhibitors. We talked about Memantine and the glutamate modulators. We talked about actually augmenting dopamine levels. Sometimes augmenting dopamine levels can actually help our patients, especially if our patients are experiencing fluctuating kind of cognitive slowing. We can optimize their levodopa, and sometimes that fluctuating cognitive slowing might improve. Now, the question as to how many patients will develop dementia, that's to be determined. However, over time, as we age, even patients without Parkinson's disease have a risk of developing mild cognitive impairment, and then that mild cognitive impairment developing into an Alzheimer's dementia or another sort of dementia on a continuum. And in Parkinson's disease, it's true that we might see a proportion of those patients that start off without any cognitive impairment develop a level of cognitive impairment, and that can be seen in, I would say, about 30 to 50% of patients throughout their lifetime.
Yeah, so that's right. So about half of patients diagnosed with Parkinson's can go on to develop dementia. And the statistics are that it can happen in about 8 to 10 years from diagnosis for those people who do develop it. So what that also means about half of our patients with Parkinson's disease may never develop dementia. So that's the other important fact. And if we start to see cognitive impairment, cognitive problems within the first year of developing the motor symptoms, that we may not really be dealing with Parkinson's disease. It really could be what we call Lewy body disease, and that's an important distinction right there. How about agitation? Where do you see agitation as a symptom of, Dr. Torres-Yaghi? We do see agitation and hallucinations and delusions. Maybe those are three common questions I've seen come up in the question and answer. So why don't we first describe agitation? What is that usually a symptom associated with?
It's a great question. I call most things great questions. I apologize. Someone told me don't call everything a great question, because then it doesn't make sense that everything's a great question. But
no,
the question.
Then you have to give a greater answer.
You have to give a better answer for each great question. That's right. See, both of my mentors, they know the right way to move things forward. So if you really think about it, what we did with this team of Dr. Pagan and Dr. Moussa is create a special clinic. Not only do we address cognitive impairment, but we also address the neuropsychiatric symptoms that can happen, neurocognitive symptoms that might occur in the realm of Parkinson's disease and cognitive impairment. Those neuropsychiatric symptoms can vary. Agitation is a non-specific symptom. So a lot of the times, agitation itself is a behavioral impact from something else that might be underlying. Dementia and psychosis, there is a large number of people or a number of people with cognitive impairment or dementia that may in fact suffer from psychosis. And what psychosis is either hallucinations or delusions. Delusions are fixed ideas. We can have a fixed idea that that people are doing bad things to us. That can lead to agitation. We can have a paranoid thoughts that maybe people are in the home. That can lead to agitation. The other things that can lead to agitation, aside from psychosis or delusions, is the normal circadian rhythm throughout our day. When the sun goes down, especially in the evening hours, the early evening hours, as we see in the winter months, we can see sometimes our patients, the underlying reason for the agitation might be confusion. But as the sun goes down, we get chemical shifts that lead us to have differences in the way we think things through. We might actually have more psychosis, more delusions during the nighttime or when the sun goes down. And that leads to agitation. So we have to really figure out the cause of agitation. Additionally, agitation might be irritability. There are many people that might manifest not just their psychosis, delusions, or any of those kind of more severe symptoms as agitation. It could be something as simple as a little bit of depression, right? So depression, anxiety, all can translate as or look like agitation to a family member or caregiver. So you kind of have to, as Dr. Pagan says, put on your detective hat. That's what he teaches all the fellows. Put on your detective hat. Don't just go by, one statement. You have to kind of get to the bottom of why that symptom is happening, why agitation is occurring, because it can be a multitude of causes.
So Dr. Torres-Yaghi brought up a very important point of what psychosis is. Psychosis is hallucinations and delusions. What we've learned over time in Parkinson's patients who are having hallucinations and delusions, and they may have dementia, they may not, is usually associated with an increase of a receptor, a serotonin receptor, known as the 5-HT2A receptor. This is the same receptor where a drug like LSD acts on. And now we have a drug called Nuplazid. Nuplazid blocks very effectively this 5-HT2A receptor, and in about 75% of patients with Parkinson's disease psychosis, we can see an improvement in hallucinations and delusions. And now we'll probably see the drug Nuplazid also in dementia-related psychosis. So there was a trial called the Harmony study, where they treated patients with Lewy body disease, Parkinson's disease, dementia, vascular dementia, frontotemporal dementia, and Alzheimer's disease, who were having dementia-related psychosis. and Nuplazid also worked in this group. So we may see this new indication in the near future. And that was a question that we also got in terms of the questions and answers of how Nuplazid works. So I think Dr. Torres-Yaghi's statement was really important, instrumental in answering that particular question as well. Dr. Moussa, how has COVID-19 affected the clinical trials? If you can be real brief with this one, and how did we overcome it? Because we just have a few minutes left.
COVID-19 did affect clinical trials nationwide, worldwide. First thing is in neurodegenerative diseases, we're dealing with people over the age of 65, over the age of 50, elderly people that are high-risk patients. So, and thank God there is a lot more awareness that, if you are in this age group or you have any comorbidities with your disease or any other diseases other than your Parkinson's or Alzheimer's, you are high risk. So there is less, it did probably affect, not probably, it certainly affected, COVID-19 affected clinical trials worldwide. The other thing is, there is something that patients should also be aware of. In most clinical institutions worldwide today, COVID-19 within the hospital is pretty much tightly monitored and contained. So clinical trials offer what I always say, another level of clinical care, a higher level of clinical care than going to your physician every 3 months or 6 months or 1 year. So these clinical trials really do help in helping patients basically address any issues that might be missed by visiting your physician every now and then. Care has to be there in place. Touching elevators, getting elevators in this with same people with other people. So practices like social distancing, washing your hands, and all the stuff that the CDC talked about. I don't have to repeat them. These are important issues. But remember, this is a high risk population due to the age and the comorbidities as well as the disease itself. But again, clinical trials offer extra care for patients.
Yeah, I think that's such an important statement that you made, Dr. Moussa. I agree with you. Definitely, clinical trials are definitely a much higher level of care, and often we're using these experimental treatments that could really be impactful to change the course of the disease or come out with better treatments. And we do see our patients a lot more frequently, and they're scrutinized a lot closer than we do just in routine clinical care. So it is a much different level of care. And again, we've taken different precautions to make sure that our patients are safe, and we definitely were able to open up our clinical trials back by late July or early August, and we're back at full steam ahead and working hard for our community. If we learned anything from the pandemic, is how important it is to come together to do research, to change things. Look how quickly we were able to come up with a COVID-19 vaccine, and not one, but multiple ones. And I think it's important never to stop the research and help mankind. The last question I'm going to talk about was a person bringing up that the last pandemic back with 1918 with H1N1, with the pandemic flu, the influenza, we did see Parkinson's as a result of it. This was we learned that it was kind of a setup for Parkinson's disease. We saw the development of alpha-synuclein from those survivors of the pandemic flu back in 1918. There has been a report of an individual developing Parkinson's or Parkinsonian type symptoms after having COVID-19. I think we need to follow that a little bit carefully. I think there's a little bit of controversy on that report that did come out because the person may have already had Parkinson's. And anosmia is one of the signs or symptoms that you can see with COVID-19, loss temporarily of taste and smell sometimes. But again, I think we're gonna learn more about the neurologic sequelae. I think the jury's still out on that report that did come out, so I think we're still learning from that. I really want to thank both Dr. Moussa and Dr. Torres-Yaghi for this great discussion. This is actually a huge topic. This is a big topic, and this is maybe a topic that we'll have to do again in the further coming months. We may just devote a series to talk a little bit more about cognition, or just Parkinson's disease dementia versus Lewy body disease dementia. Maybe talk about some of the clinical trials that are currently ongoing, because this is a very, very big topic to tackle in just 1 hour. And we can see from the amount of questions coming in what great interest there is. And again, I think from tonight we learned about some great research is happening at Georgetown, and some groundbreaking research about the vascularization, about the blood-brain barrier with some of these genetic changes after nilotinib, after a year or so. So I think we're still continuing to learn. It's my pleasure to always work with these two gentlemen and all the fellows. So thank you very much. I want to thank the development team, Rick and Janice. So Rick Shannon and Janice Buchanan, the founders of Fund the Fellow, and the development for the support of training our fellows over time. I want to thank the fellows for all their hard work, but without them, we can't do this research. Barbara, Joy, have all the different attendings, all 10 of you, you know who you are. You're phenomenal at teaching these fellows and working together as a team to really help our community. And everybody, I hope everybody has a wonderful holiday season, and I hope you have a wonderful 2021. Thank you for your participation tonight, and thank you for your support. We really do appreciate it from the bottoms of our heart. God bless you all. We're looking forward to 2021. We look forward to the next one. Bye-bye.